Yeah, so welcome. Can you hear us, Arno and Peter?
Yeah.
Yeah, perfect.
Yep.
So I really want to be discussing this with you guys and with Dominic de Wolf, who we've got in the room, about exactly, because this is quite a common problem, I think, in Barrett's esophagus. A lot of people out there managing patients with Barrett's, just about how you can, first of all, do measurements in Barrett's. Second of all, how you make sure you assess that it is actually Barrett's you're dealing with. And thirdly, you may have spied something already, how you decide how to manage a dysplastic Barrett's. And just maybe a question straight up to Professor Lammers. What's your opinion about Barrett's of this length being managed in the community? As in not in a reference center for Barrett's.
Yeah, we know the guidelines, of course, but in my experience, people refer those patients quite quickly, and we have many surprises. We welcome patients for in an attempt to perform RFA ablation, and in every case, of course, we rescope this patient for staging with high quality endoscopy, and sometimes we do not find any dysplasia, or sometimes we found advanced lesion like T2 or T3. So it's always a gambling to know what will be the surprise when scoping the patient. Yeah. And I hope with the time we will have much more and more patient having the right indication directly coming from other center. But I'm okay with you that I think those very high-risk patients need to be followed by experts.
And so you can understand, looking at this, that an ESD-only strategy doesn't make sense in economic terms. It's also very important to say that these are not weighted equally. So the high-risk lesions are not as common as the low-risk lesions, and 75% of the lesions are the low-risk type of lesions, therefore weighting the numbers even more away from doing ESD for every patient. So in the majority of cases, EMR is the preferred strategy for endoscopic resection based on the risk of submucosal invasive cancer. Could we get even more into that? We could get into the cost of that, and a decision tree analysis by Bahin and Heitman, published in Gut 2018, shows exactly that if you adopt a strategy where you do ESD for every single lesion that you find, you could prevent 13 surgeries per 1,000 patients, but you would spend $210,000 per surgery avoided. So a universal ESD strategy doesn't make sense financially. A selective ESD strategy may do, and that is where you select the high-risk lesions to perform en-bloc resection, and for the rest you perform piecemeal EMR. More on that in a minute. So an en-bloc resection is not required for the majority of laterally spreading tumors, as they are at very low risk of submucosal invasive cancer if you can't see endoscopic imaging evidence of it. Even in tertiary center practice, even in the best hospitals at EMR in the world, this is still the case in over 75% of the lesions. So in most cases, in most practice, that's 95% or more. A novel technique to reduce adenoma recurrence was published in Gastroenterology at the end of 2018, showing a 4-fold reduction in the active arm versus the null arm, both in endoscopic recurrence and histologic recurrence at first surveillance colonoscopy. That is important, very important, because it means that now we can really prevent recurrence happening before the surveillance procedure. But if it does happen at the surveillance procedure, then this nice study presented at the ASGE Presidential Plenary in DDW in 2018 and currently in write-up showed that the majority of lesions where there is recurrence at the scar can be treated again endoscopically with good, about 90% durable, long-term adenoma-free outcomes. And this has also been demonstrated in much smaller cohorts previously as well. So what is the last important message? Well, I think endoscopic mucosal resection properly performed with complete thermal ablation of the post-EMR margin is 4 times as efficacious as it was 2 years ago, without any, and any remaining recurrence can be treated endoscopically. So what should we do? Based on this, based on everything I've just told you, when should you do en-bloc resection? If you consider that you have a colonic polyp, maybe it's a flat laterally spreading polyp, it could be any polyp, you look with endoscopic imaging, you look whether there's overt features of submucosal invasive cancer. Is there a demarcation zone? If there's ulceration and it's clearly deeply submucosally invasive, it should be for surgery. But if not, and there's a demarcation zone, then it's for en bloc resection via en bloc EMR or ESD. But if you don't see anything on the surface, if it's at high covert risk, and so we've talked about if there's chance of buried submucosal invasive cancer, bulky, left colonic, non-granular lesion, that probably should also be removed en bloc. Whereas a low covert risk lesion, we should either consider en bloc EMR if it's quite small, but I would argue in most cases piecemeal EMR for the reasons I've stated and the higher incidence of adverse events with en bloc EMR.